Are there pharmacokinetic and efficacy differences between IV and sub-Q? That's a question people always ask. You know, you guys want to?
So largely when we look at, so for instance, the initial staging for getting FDA approval for trastuzumab subcutaneous, so HANA-H was the first study. It was really looking at that flat dose of 600 milligrams. So, and they found similarly non-inferior trough concentrations, and they actually looked at pathologic CR for those too. And
it was neoadjuvant therapy, right.
Exactly, and they found no difference in the trough concentration, and actually in some cases at least
it was higher, I think, wasn't it? Yeah, it was a little bit higher.
With rituximab studies as well. So there's really no difference per se in the PK for trastuzumab subcutaneous.
Are there bounds for trastuzumab beyond which we don't have a well-described PK curve in terms of very low or very high BMIs or other problems?
So the way that it was phrased in the the HANA-H and the follow-up studies to that is that there was really no difference regardless.
They actually did BMI. Yep. They did the upper quartile of BMI and the lower, and they found there was no difference in PK.
Yeah, I don't believe even on the extremes there was.
There wasn't, right? They did that on purpose. I saw that stuff in the HANA-H. And the interesting thing about HANA-H is they actually, I don't know if they did this with lymphoma, but they recently published data, a follow-up to it, showing, like we know in breast cancer, that if the PCR rate is roughly the same in neoadjuvant therapy, the disease-free survival at 3 and 5 years is basically the same. And it tracked. And so they show that in HANA-H that it did track, which I guess you said they don't really have that data for lymphoma yet.
We haven't seen published longer-term outcomes. We have the earlier outcomes where there was no statistically significant difference.
Right. Okay. So the question is, so the FDA requires what? What exactly does the FDA require before they allow this to come to market?
So initially, the first step is looking at non-inferiority for pharmacokinetic exposure, right? That's the very first step.
So it's kind of like biosimilar in a way.
Exactly. Yeah. Second, they're looking at safety and efficacy. So that's where we're comparing to look at these endpoints. We're looking at our CR rates. We're looking at our PFS for our rituximab patients, and we're looking at safety endpoints to see is there a difference in any adverse event. So when we think about trastuzumab, cardiomyopathy, things like that come into play, right? Similar rates were found for that too, right?
Because one would expect, you could argue, oh, it's a higher flat dose, more, you get more cardiomyopathy. No, I get it. So it really wasn't. It was the same.
Exactly.
Yeah.
And to that point too. So the recommendations for cardiomyopathy, right, for trastuzumab subcutaneous, largely the same. Your baseline echocardiogram every 3 months during therapy, that kind of thing remains the same based on that data.
Got it. So are there any contraindications to sub-Q dosing at all that you guys know of?
When we approach patients, it's really, is there an intact integument, right? So if people have chronic skin disease, which certainly can be a problem for patients who have some forms of B-cell lymphoma, where you may just feel uncomfortable, frankly, in treating through the skin. But the number of situations that have arisen clinically that I've said, I'm not comfortable giving you sub-Q treatment on the basis of comorbidity or physiology. I honestly can't think of such a
See, the
case.
one I would expect from my nurses are low platelets. Someone walks in the door with a platelet count of 25. I'm sure my nurses will say, Dr. Brusky, you can't do this. You've never had that. This is really important to put online. I'd like people to know this, that is not an issue.
That inquiry has definitely come up. I know that that's come up, and I'm sure that's come to you from the treatment team, but it's definitely not something that we've run
It'll
into
always
as a
generate a
problem.
phone call, but
I think so.
But generally, it's not. I mean, it's reassuring to know you can do this with low platelets.
In my opinion, there is no platelet count below which it is not safe to give sub-Q rituximab.
And with lymphoma, there have been some pretty low platelet counts.
We see them low.
Right, exactly. Okay, good. I got it.